Thank you very much for having me, and thank you all for being here. I would like to talk to you today about the added value of psychotherapy in the genetic counseling process. And I thought I would better start by saying a few words about my background and by acknowledging some of my biases. So I was trained in clinical psychology, and I was also trained in CBT. And for quite a few years, I worked with patients and families that were dealing with major depression and anxiety disorder, personality disorder, schizophrenia. And when you get to know not just the patients but the families, and you get to see the process and the dynamics that they all went through, I just knew I needed something more, and it was with quite a lot of consideration that I chose to get training in genetic counseling, and I did the course in Manchester. So for nearly 10 years now, I've been worked pretty much in both professions, and it was my aim from the very beginning to try to bring the two together and just try to wear two hats at the same time, if at all possible. So I know everyone knows quite well what genetic counseling is, but I just wanted to stress again that what we all do, we try to help people understand and adapt to the medical and psychological and familial implications of the conditions that they are confronted to. And what was even more relevant for me than probably this definition is what Kessler said from the very beginning, is that genetic counseling is in itself an interaction with a very strong psychotherapeutic potential. So I wanted to start a bit from this definition. And also to acknowledge some of the goals that we all know genetic counseling has had over the last decades, and it's clearly there are goals that have been evolving over the last decades, but they also evolved along a continuum. So we always aimed to help patients understand the conditions they had or they were at risk at, to maximize their options, but clearly to help them facilitate coping and their adaptation to risk or the condition they had. We always focused on improving self-efficacy and decreasing stigma and emotional distress. So clearly we have always done that to quite a great extent. So if we look at the literature, and if you were at the workshop earlier, you already know some of the data that we have so far, we clearly know without any doubt that genetic counseling is effective, and we have so much data to show that. We know that genetic counseling does improve patient knowledge, it improves the accuracy of risk perception, it decreases emotional distress, it's a huge help in increasing the autonomy in decision making. It deals very well with stigma, and it generates high patient satisfaction. So there's no doubt that genetic counseling is effective, and we know that if we look at any or most of outcome studies that have been published over the last few decades. We know a bit less about the genetic counseling process. So research that looks at the process of genetic counseling is less robust. But what we do know is that the structure of the genetic counseling session generally tends to be quite similar. We also know that the goals in genetic counseling sessions tend to be fairly universal. The strategies and the skills that we see professionals using and other professionals teaching and training are very much compatible with these goals. And the outcomes that we all aim for are pretty much similar, and they are obviously quite obvious when we look at the outcome data. What we also know is that genetic counseling sessions tend to be a bit more educational, with less emphasis on psychosocial and emotional topics. So I think the data that we have is quite robust. It is effective, but we tend to focus a bit more on the educational aspects. And the state of the art looks the way it does, probably due to some of the challenges that I think we are very much aware of. One of the challenges is that professionals come from many, many backgrounds, and they are trained in genetic counseling, but their counseling skills most often remain uneven, and this is partly due to their backgrounds. We also have quite a bit of research that shows that genetic counseling providers tend to equip patients, families, clients with scientific information, hoping that if they understand that information, if they understand the big picture of that condition or that risk or those numbers, they will feel better and they will make more informed decisions and they will actually have a better outcome. So often we see research that shows that professionals, genetic counselors, tend to remain quite neutral in their counseling. However, we know quite well that from research and the interaction that we have with each other, genetic counselors tend to have quite diverse views, personal views, and approaches to psychological aspects and outcomes when they do genetic counseling. And even if it's not a very informed or intentional process, most of us are rooted in different traditions, and there are quite a few psychological counseling models that are being used in genetic counseling, such as CBT or person-centered models, family system, psychodynamic, and so many others. What I couldn't find in the literature and what seems to be lacking is an overarching framework or something that brings together all these models that we have and all the data and techniques that we know are out there but just don't seem to be as present as they could in our practice. So can we do better? Is there any room for improvements? So from my perspective, and I will just try to shift to my clinical psychology or my CBT background, it's quite obvious that some of the components in the psychological components where we really have a lot of data and that we know are very well supported by empirical evidence, they're not always as well reflected in the genetic counseling practice. Evidence-based genetic counseling is still emerging, and that's quite obvious, but when compared to the evidence-based approaches and data that we have in psychotherapy, there's quite a big difference. And obviously we all know that we are confronted with really, really difficult situations in sessions, and sometimes I have the feeling that there's so much data out there that we could actually use to help us and help the patients or the families that we see. They're obviously not new challenges, and it's not something that's just recent. These questions were asked by others before, and there were quite a few papers in the 80s, and if you read some of them are really enlightening and really recent on so many levels. So we did ask these questions for a long, long time, and we have very good and interesting recent papers that have dealt with the exact same questions. How psychotherapeutic is genetic counseling? How much do we actually use from the data that we have available? And before I move on and tell you some of the things I have in mind or are of interest for me in particular, I would like just to mention a few things that we know about psychotherapy. So what we know is psychotherapy really works. We have so much data. There are thousands and thousands of papers and hundreds of meta-analyses that have shown that psychotherapy is efficient, and it works for more than 75% of patients. And not only it works, but the benefits that we have after psychotherapy tend to be long-lasting. We also know that we don't have and we can't really see any significant differences between between various forms of psychotherapy. Some forms of psychotherapy, some approaches seem to have a bit probably more empirical support, because that was the approach that they had from the very beginning, gather empirical data to support their models and techniques. But basically, if we look at the big data, there are not big differences among the various forms of psychotherapy. If we try to zoom in a bit more and think, why does psychotherapy work? What makes it work? Just because it could obviously give us an idea of what we could do in genetic counseling. I'm probably not doing that as much as we could. There's a vast literature on the contributing factors that have been shown to have a role in the efficacy of genetic counseling. And we can always see papers looking at patient variables and therapist variables, and so many papers looking at the process of psychotherapy itself. And if we look at the process, there are quite a few active ingredients that have been investigated over the years. And as an overarching framework, if you like, that we can always, and the literature always talks about specific factors and common factors. So what we do know is that there are a few elements that are common to most forms of psychotherapy, and such as the therapeutic alliance, the working alliance, or therapeutic relationship. It depends, I think, a bit on the framework that we use. These are factors that will always play a role in the psychotherapy efficacy. So having expectations to get better, having a good relationship with your therapist will always contribute to you getting better. There are also a few specific factors, that is, factors that are very specific to therapy paradigm. For example, in CBT, restructuring some cognitions or some of the dysfunctional thoughts that someone may have is a very specific technique, and it's a very specific targeted outcome that we look at. So some of the factors or some of the processes are really, really theory specific, but most of them are not. So this is a very famous picture that is actually very recent, because there's recent data, but I chose to put the 25-year-old's picture because it's just as recent. Data shows that 40% of the outcome in any patient across therapies and across emotional difficulties, because it's obviously not always emotional disorders, 40% is explained by client factors. That means factors that are not dependent to psychotherapy. That may mean family or social support or religion. So there's something outside therapy that actually helps me get better. 30% of the results is explained by the relationship that I have with my therapist. So if we have a good working relationship, if I feel that I'm unconditionally accepted, if I feel that we're working towards the same goal, if I feel a positive regard and respect, if our relationship is therapeutic, I will get better. 15% is explained by expectations, placebo. So just knowing that I'm going to see a professional helps me from the very beginning. Knowing that I'm seeing someone that knows what he or she is doing is already helping me. So that, again, is a factor that's common to any psychotherapy intervention. And only 15% seems to be due to very specific school theory-driven techniques. That means that most of us, I think, get a lot of training to try to, to the best of our knowledge, get to focus and be good at what we do with that 15%. The good news is that most of the results in psychotherapy we get from common factors. Obviously, we can use very specific techniques, but there's you can feel, I think, quite a lot of hope when you look at big data like this. And I mentioned the Working Alliance as being the best and constant predictor of outcome in all therapy models. And it's effective because, and there's a lot of data about that, Working Alliance tends to be very efficient and tends to have a really important role because we use empathy, positive regard, collaboration, and shared goals. So if we look again at what Working Alliance is, in the context of psychotherapy, it's quite clear that we do that in genetic counseling, don't we? So this is something that we have always done. So clearly, what we know from psychotherapy about Working Alliance is very applicable for genetic counseling. I didn't do a very systematic research on this, but I did look at the most relevant or probably visible websites that describe the genetic counseling skills and competences that should be taught and should be practiced by professionals. And if we look at them, it's just Working Alliance, evidence-based Working Alliance. We need to use empathetic listening, we have to provide unconditional self-acceptance, we have to provide psychological support, establish agenda, facilitate patients to reach autonomy and help them make decisions, promote coping strategies. So what we teach and what we do is, to a very great extent, evidence-based Working Alliance. So I think we obviously, as genetic counselors, have a lot in common with psychotherapists on so many levels. What I think is distinct probably is that most of the concepts that we used are not really specific to a form of psychotherapy. What we do know is that clearly patients value that. And there are a few studies that were published in the last few years that have shown that the most important things that patients value are often of psychosocial nature. They value empowerment, they value adjustment, they value satisfaction, they value feeling understood and being heard. And most of the times meeting those needs actually helps them make more informed decisions and have more healthier behaviors and adapt better to the difficulties that they are confronted to. And very interestingly, attention to psychological needs does not seem to improve the session length. So actually it's not an extra burden for us as professionals. So this is something we can actually do if we're not doing that already. It's clearly really helpful. It's helpful for patients because they feel more empowered, and this is what they most often come to see us for. They have better results, and it doesn't take much longer anyway. So clearly we have done so much over the last 4 or 5 decades, but the question is, and this is where I have a few questions, I think, quite rhetorical to be frank. Can we do more? Can we draw more from the theoretical frameworks that are available and from the empirical evidence from clinical psychology and psychotherapy? Can we borrow something of clinical psychology and psychotherapy to make actually our genetic counseling process better? Can we facilitate? Can we do anything more? Is there anything about common factors? For example, we do that, don't we? The Working Alliance, but are there any common factors that we could maybe do more about? Are there any specific factors that we could probably include in our session? Do we want to know more about some behavioral strategies that other forms of psychotherapy use? Do we want to use metaphors in our sessions? Do we know how to use them? Are there any cognitive techniques that we might want to use that are known to have really solid empirical support in helping patients, for example, with anxiety or depression or anger or shame? Is there anything that we could do more? And I think for me personally, one place to start is actually stop and devote some time for self-reflection and just ask ourselves for just 1 minute every now and then, is there something that made us uncomfortable in a session? Is there something that we're avoiding? Is there something where we don't feel confident enough, or where our self-efficacy levels are not that great? Is there something where we think we need help? And obviously, and we talked about that, I think, with many of you over the last couple of days, this is something we do, the one of us that are quite lucky and have supervision. So this is something we do in supervision, or this is something we can discuss with colleagues. Another technique that was quite useful in many genetic counseling papers, but psychotherapy as well, was audio taping the sessions and actually hearing ourselves do the session and just seeing ourselves do something. So would that be useful? For me personally, as I said, it was really, really useful to have some guidance when I first started to work in genetic counseling, to have a sense of direction. So it felt pretty much like this, in the sense that obviously you don't really know you're going to get there, you don't really know you're going to do a good job, but at least it gave me some, I think, efficacy and some confidence that I know how to deal with a difficult situation, I know how to deal with grief, I know how to deal with anger and shame, depression if I have to. I know how to ask about suicidal thoughts. I know I'm not scared of patients, and it doesn't make me uncomfortable to address some of the things that can be quite emotional or intense. So knowing that I have with me techniques or strategies, even if they were really unconscious and at the back of my head somewhere, I felt more equipped to deal with some of the sessions, and some of them were quite difficult. So for me personally, having a background in psychotherapy, it doesn't have to be obviously a proper training, it doesn't have to be CBT by any means, but having some training in psychotherapy, for me personally, it was really, really useful. So I think it's quite likely that having a framework in psychotherapy, in clinical psychology, might actually be really useful, because it can help us make predictions about how patients feel, why they feel the way they feel, and how they might respond in the future. It can show us how we can better help the patients, because there's so many resources available. There's so many books and guidelines and so many gifted professionals that can help us be better at what we do. And sometimes it's just it's not infinite, but it's a huge source of inspiration and techniques and strategies that we could use, and maybe it's something that we didn't really think about. I don't think it's quite easy to do that. I think in theory it sounds really good. In practice it might be a bit more complicated. In theory it sounds good because, as I said, as a profession, we're quite similar in terms of training and process and outcomes. So we do pretty much the same thing. But if we look at us individually in practice, it can be a bit more complicated, because obviously we come from different backgrounds and we have other priorities, and we work in different healthcare systems. So of course it's going to be very challenging, and by any means I don't think there's a single model that can be applied everywhere. And I know we deal with a lot of heavy caseload, and I know we don't have a lot of time for most of our sessions, and we also tend to be quite comfortable with sharing really up-to-date information about genetic conditions and risk and strategies, and we do that very well, obviously. And another thing that we probably struggle with, there seems to be quite a bit of gap between training programs in terms of the counseling skills that we teach and then use. compared to the state of the art in clinical psychology and psychotherapy. So if we look at the future, near future probably, if we want to think of where do we want to go from here, if we want to do that, probably, in my view, more than anything, using a psychotherapy framework could actually be really useful to guide our practice, because it has the potential to enrich our work. It has the potential to help us be better, more comfortable, more confident, and it has the potential to help the patients even more. It can, having a psychological or a psychotherapy model in mind, can inform our practice quite explicitly if we want to get proper training, but it can inform the practice, it can just support our practice. We can have courses and we can get additional training, CPD training, and just have constant support and constant supervision from someone that is very experienced in teaching or in supervising genetic counselors, but obviously having a more psychotherapy-based background. In terms of research, I think also looking at potential psychological models can be very interesting and enlightening, if you like. We know genetic counseling is effective, and we know it's effective because recently we have access to more and more data where we have measures before and after the genetic counseling sessions. So empirically, we know it works. But most of the times, we don't really know exactly what makes it work. So what is it that after one session or two sessions of genetic counseling, someone feels so much better for such a long time and makes big decisions that will affect the rest of their lives? What exactly in that session triggered that change? So are there any active ingredients we want to look at? Is there anything we might want to have in mind when looking at our work as genetic counselors? So that's one question I had in mind, and having in parallel my psychotherapy background, I'm always tempted to look at the research I know from psychotherapy, and I know some of the things I would look at, and then you PubMed research in genetic counseling, and it's really interesting. There's really not much out there, and it feels that probably some additional work or some psychological models or approaches could actually inform not just the practice, but some of the research that we do. The literature is also surprisingly lacking when it comes to genetic counselors' characteristics. So is there something about us personally that makes genetic counseling work? Or is there something about some genetic counselors compared to others? Are there genetic counselors that tend to have better results than others? There's a very good example in psychotherapy, and we always say, why do we always randomize patients to therapists and we never randomize therapists to patients? Is there anything about us that actually explains why our patients get better? Obviously, having any psychotherapy model in mind, I think could shape some of the research that we do. So that's one of my biases. I'm a big fan of research and a big fan of combining psychotherapy and genetic counseling, and I see research potential everywhere. But I think it would actually make a big difference knowing what exactly makes genetic counseling work. Can help us make it better and can help us have enrich our practice, our research, and our training. There are a few papers and there are a few really interesting voices and opinions on the fact that counseling skills of genetic counselors need to be revisited. I'm not an expert, but maybe this is something we might want to have in mind. And probably if we decide that having a therapy or a clinical psychology model in mind would enrich our practice. Maybe training in counseling skills could be upgraded, and basically counseling skills could and should, in my opinion, be given as much privilege as that we give to knowledge about statistics and genetics, because obviously counseling skills and what we do, the psychosocial aspects of the genetic counseling sessions that we do actually tends and seems to make the biggest difference in terms of outcome. Supervision, I already mentioned, and continuing education in counseling skills is obviously essential. So, in my view, having a psychotherapy model in mind is helpful on so many levels, but it's only helpful because genetic counseling is in itself therapeutic. So it's really easy to borrow a model, or to borrow a technique, or to borrow an outcome or a measure or a process or research, because psychogenetic counseling, and we know that from so much research available, genetic counseling is therapeutic. There are some gaps that we know about, and we might want to address them. But clearly, when addressing them, a model is not necessary. We don't have to get trained. We don't have to be psychoanalysts. We don't have to be CBT therapists. We don't have to do that. But we can use models or overarching frameworks that would inform our practice more and would help us be better at what we do. I would just like to end with in the same notes that I started. And I think one of the best things about our practice as genetic counselors, and I think you would all agree that we like a good challenge, and I think a good challenge in our case is combining our skills to educate and to counsel patients in what Kessler says, unusually gifted and flexible professionals. So I think if we have that in mind, that we are and should be unusually gifted and flexible professionals, we would probably be so much better at what we do. And it's quite enlightening, I think, when you look at the research and the practice, and we look at ourselves doing what we do and being where we are, really. That's all. Thank you.